Here we go. Warm welcome to you from Geneva Learning Foundation. Even though I'm not currently in Geneva, Switzerland, this is Reda Sadki from the Geneva Learning Foundation. I'm actually in Bangkok, Thailand this week. Charlotte Mbu, Mistress of Ceremonies, is in Ibolova, Cameroon. Charlotte, how are you doing? Are you ready for this opening ceremony, which I believe is quite important for all Teach to Reach participants?
Definitely, Reda. Hi, everyone. It's a pleasure for me to be here, and it's a pleasure for me to be able to introduce to you the women who deliver vaccine, who will be opening this plenary today to talk about a topic that is current, and it's a current public health concern. So really excited to be here and looking forward to that, Reda.
Wonderful. So we have two parts to the opening ceremony, but we'll probably be spending most of the time on the opening from the Women Who Deliver Vaccines collective. This collective was created in 2021 for International Women's Day and has been going ever since, opening Teach to Reach and making many other contributions. A reminder of the rules we have in place for fairness on speaking in the Movement for Immunization Agenda 2030 that Teach to Reach is a part of. If a man has spoken, the next person should preferably be a woman. If a person from one country has spoken, the next person should be from another country. Now, before we do the opening, here are the numbers for Teach to Reach 8. And get ready for this. We'll start with Teach to Reach 6, 12,396 participants. Teach to Reach 7, we got to 13,676. And believe it or not, for this edition of Teach to Reach 8, 9,335 English speakers, a grand total combined both languages of 16,835. And again, we say this every time, it's quite important. It is not about the connections you have with us, with me or Charlotte or the Geneva Learning Foundation. It is about the connections you have with each other. What you're seeing on the screen is a graph we show very often. It's social network analysis showing how you at Teach to Reach in the Movement for Immunization Agenda 2030 are connected to each other. So that as a preamble for this opening ceremony. And now over to you, Charlotte, to lead this opening ceremony by the Women Who Deliver Vaccines.
Thank you, Reda. The Women Who Deliver Vaccines is a collective of 143 women from 38 countries that came together in 2021 to see how they can support one another, support women from all health system levels to promote the immunization agenda. And today, to open this Teach to Reach, they will be talking about the work that they are doing to promote HPV vaccination. We know that each year, there are 600,000 new cervical cancer cases that are registered, 340,000 deaths. And with the pandemic, there was a backsliding of vaccination coverage from 15% to 12%. So today, to open this ceremony, we have Penina Okecha that is joining us. I'm inviting her to unmute to talk to us about how she has made HPV vaccination to work amongst young girls. So Penina, if you're able to unmute yourself, and please do start. I know your details are on the screen, but can you start by introducing yourself and share your story?
Good afternoon, everyone. My name is Penina Okech, as Charlotte has said. My story is based on experience on HPV vaccination at district level in Kenya. So, Charlotte, can I go ahead?
Yes, please go ahead, Penina.
Yes, so how I made HPV vaccination work for the girls and women, I started by being one of the champions on talking about the importance of receiving the HPV vaccine. And the messages were key to specific points about the importance of the vaccine. I also participated in microplanning for the HPV vaccine needs to enable us have enough supplies for the girls, and also target and map out the girls who are in school and those who are not in school, who are actually eligible for the vaccine. So I started by, first of all, being part of the team that was sensitizing various groups, including the men, women, teachers, and youth about the vaccine. There were leaders in each and every group that were recruited to support us and champion about the acceptance of the vaccine. We shared a lot of key messages through flyers and IEC materials, which we ensured that through the health promotion officers, these IEC materials were placed strategically for the public to read. And we also held radio talk shows, which were on the benefits of the vaccines. So we also worked together with the teachers because most of the girls who were eligible for the vaccine were actually, most of them were in school, even though some of them were out of school. So the situation before that was that there was a lot of resistance for the HPV vaccine because one, there were rumors that it was a family planning method targeting the young girls. So even though a few health workers and the teachers had been sensitized on it, prior to the launch of the vaccine, the uptake still remained very low. So the strategy from the Ministry of Health was that the girls were supposed to visit the health facility to receive the vaccine, but it didn't take off as expected. So the numbers went low, and we had several vaccine doses which expired as the health workers waited for the girls to come to the health facility. But thanks to the strategies and the wake-up call from the Ministry of Health, we started by talking to the stakeholders, and we were supported to do microplanning and still map out the girls. And a lot of outreaches were done. And during that same period, periodic intensification of routine immunization was conducted. And the age group for the girls who were supposed to receive the vaccine was expanded. And then during COVID vaccination, we also included them, the girls. We did both the vaccines at the same time, and also included the immunization stamp at the entrance of the health facility, so that if any girl was visiting a facility, then they would be screened for the vaccination status for the HPV vaccine. If they were not vaccinated, then at that point, they will be offered the vaccine. So together with the other stakeholders, including teachers and community leaders, we came up together and ensured that we reach out to all the girls, and it turned out well because now all the girls were sensitized to receive the vaccine. We also ensured that the schools had an updated register of the girls who are due for each dose, and worked together with the teachers, included the teachers in any planning meetings for the vaccine that was supposed to be administered to the girls. So in summary, the key, what was key to HPV vaccine acceptance was that initially the information had not reached the public. And so we focused on giving key facts about HPV vaccine and the benefits of the vaccine to the girls. Thank you, and over.
Thank you very much indeed, Charlotte. I believe before we hear the next experience shared, we have a guide on the side who has joined us, looking to...
Yes, Reda, are you speaking? Because I'm not able to hear.
Are you able to hear me now?
Yes, I can hear you now, Reda.
All right, you see, everyone, really everyone has these issues. So yes. So my question to you was, what shall we? So first of all, thank you, Penina Okech, for this first experience shared. What shall we do next, Charlotte?
Yes, Reda, I would like to warmly welcome Law Anais Zota. That is our guide on the site today. And just to explain a little bit, what do we mean by guide on the site? To us, it's the opposite of a sage on the stage, which is that expert that comes to give you a lecture or a PowerPoint presentation with all the technicalities and technical details around HPV, which is the case in point today. But instead, we have here a guide on the site, Law Anais, that has accepted to come and listen to your experiences, to learn from you, and also give you feedback and useful insight of what she is learning and hearing from your experience. So I'd like to turn towards, before we go to our next speaker, I'd like to turn towards Law Anais. If you're able to unmute yourself, please, will you start by introducing yourself and telling us what you think about the story shared by Penina Okech around HPV vaccination in Kenya?
Thanks so much, Charlotte, and thank you for having me here today. So let me just give a quick introduction. My name is Leone HPV. I work in global vaccines delivery for the Clinton Health Access Initiative, or CHAI. I'm based out of Kigali, Rwanda. So I'm also going to be off video because my connection is not the most stable today. But at CHAI, we support about 15 countries with vaccine coverage improvement and equity program, as well as new vaccine introduction. And I lead our HPV work. So at the moment, supporting countries like Nigeria and Indonesia with planning their national introductions, previously smaller countries like Sierra Leone and Lesotho, as well as Ethiopia, and have ongoing work in Kenya, Cameroon, Uganda as well to improve coverage in these countries. So really wanted to express my thanks for having me here today. Very much looking forward to hearing from the insights from all the colleagues on the call who work across many different countries and contexts and the discussion coming out of it. And thank you so much, Penina, for sharing your experiences and this inspiring story on boosting confidence in the HPV vaccine. I think we all know that HPV is one of those vaccines that require a lot of work on tackling hesitancy and making sure that all stakeholders are comfortable with the vaccine to ensure that we have good uptake. And what I've taken away maybe from your story is the engagement you've done with not just the women and the girls, but all the other influences that lead to a decision on taking the HPV vaccine, so including men and teachers. I think in all countries we have found that teachers are such a crucial part of building confidence in the vaccine as a trusted source of information. And I was really interested to hear as well the flexibility approach that you adopted in making sure that girls were vaccinated in school, but also during the COVID vaccination campaign, as well as when they showed up at health facilities, really making the most of every and each interaction that the girls have with the healthcare system. I think that's that flexibility of not considering just one service delivery strategy, but all the ones that could lead to vaccinating girls against HPV is very, very inspiring.
Okay, thank you very
Charlotte.
Yes. Thank you very much. Laura. I would like to turn to our second woman who delivers vaccines, Fanny Ogu. Fanny, are you able to unmute yourself to tell us about the work you are doing in terms of educating young girls and community around HPV vaccination? Fanny, I'm asking you to unmute.
Yeah. Okay, good afternoon, everyone. Hello?
Yeah, good afternoon. Please
everyone.
Introduce yourself.
Okay. Yeah, I'm Fanny Ogu. I'm a nurse epidemiologist, implementation researcher, and immunization professional. I retired from services of Federal Ministry of Health as an assistant director of nursing services. And volunteering my services, independent immunization volunteer at a rural district of primary healthcare center in Delta State. And I'm an alumnus of TGL. That's who I am. So coming to the HPV, with this intimidating statistics that I'm seeing on the screen of 600,000 new cases every year, and Nigeria as a country, there is no endorsed HPV vaccine immunization program in Nigeria. The cost of available vaccines is so high that people cannot afford, and the low health insurance scheme is yet another challenge. So there is zero knowledge about HPV vaccine, abysmally low in Nigeria. So an occasion presented itself because as a volunteer, as an immunization volunteer in the district, I was working to address zero dose and under-vaccinated children, engaging in community risk and communication with stakeholders, rollout of new vaccines. So along the line, we decided to carry out a campaign on menstrual hygiene and practices, knowledge and practices of menstrual hygiene among secondary school girls in a rural community in Delta State. Along the line, we decided to field in questions on HPV. And surprisingly, of over 120 students that we presented these questions to, nobody knows anything about it. The few that had an idea because of the common words, the H and the V, were telling us that mistaking it for HIV and AIDS. So the outcome is that there is no knowledge about HPV vaccine in the rural communities. So what we now decided to do is to come together with this objective of providing HPV vaccination awareness campaign among adolescent girls in secondary school, in the rural secondary school in Oliogo. Then to initiate HPV screening for women between age 15 and 49 years of age. The idea of initiating this screening is that by the time some women undergo the screening exercise and some cases are identified, that will arouse the community and the dwellers to know that there is HPV cancer-related cases among the rural dwellers. So what is here now, the strategy that we have put in place is community engagement with men and women leaders, religious leaders, and training of healthcare workers on interpersonal communication risk skills, so as to build capacity for effective service delivery, collaboration and partnership with political leaders, philanthropists, so as to fund the provision of vaccines, because the cost is not within the reach of the ordinary person. That is what we're trying to do, and we want to do this so as to carry out this exercise on the 11th of October this year, 2023, ahead of the introduction of the HPV vaccine into Nigerian system, as announced by the WHO representative, that come November 2023, there will be introduction of HPV vaccine into our system. Then,
Thank you very much.
Thank you so much, Fanny, for sharing with us all that which you're doing, your engagement in preparation for the introduction of the HPV vaccine in Nigeria. So before I turn to our guide on the side, I would like us to listen to a man, because the women who deliver vaccine have always been supported by the men working in immunization. And I would like to invite Bilé Nestor. Rather, his story is among those that are in the slide deck, to share with us his experience with HPV vaccination at the district level in Cameroon. Over to you, Nestor, and please do start by introducing yourself.
Thank you very much, Charlotte. Hi, Reda, and everyone on board. I am Bilé Nestor Binkar. I am a medical doctor. I was working as a district medical officer in Cameroon, in one of the districts in the northwest region of Cameroon. Yeah, I really want to thank you for giving me this honor and pride of place to contribute among women who deliver vaccines. You know, anything that has to be successful has to start with women. And when we are growing up, we knew that nurses were only women until we got to a certain level. So I want to thank you very much for giving me this opportunity to contribute, especially when we are talking about the women delivering vaccines. Yeah, in Cameroon, before the introduction of HPV vaccine, about a month prior to the introduction of the vaccine into routine immunization program, there was a letter written by one of the top profile religious leader giving instructions that the vaccine should not be administered in any health facility or school within his jurisdiction. So this particular letter was widely relayed by social media and some media houses, and that brought us a lot of problems. We had difficulties convincing people to get the vaccine, although we understand that the Minister of Health had some working sessions with the bishops and others, but at the end, I'm not sure there was a formal letter that was written to really stop the implementation of the official information that came before. Where I worked, the Catholic Church plays a very important role. Some of the health facilities, about a fifth of the health facilities are managed by Catholic Church, and majority of the Christians or majority of the population are of the Catholic faith. So this letter from the high-profile leader from the church brought a lot of resistance, and these particular health facilities, we are very reluctant in engaging in HPV vaccination activities. So although their position was not really clear, they didn't come up clearly to tell us that this was the problem. Some were clearly not really ready to start implementing HPV vaccination. So I had working sessions with them. I had advocacy meeting with them, but some tried to change, but others were still reluctant. So I was trying to find out if there was an official position from the Catholic Church in general, and I feel I came across a position paper that was written by Catholic Medical Association. Is like a governing body that also looks into the ethical issues related to certain maybe vaccines and the Catholic faith in general. And it was recommended that the decision to vaccinate the girl child, should be taken by the parents and not the church. So I used this particular position letter to do my advocacy, and also share the letter with my colleagues and even the regional coordinator for EPI activities. So we have been exploiting the letter, doing advocacy, and although we understand that the HPV coverage is still low, but it has been improving when we came across, since we came across that particular piece of information. So I think I shared the link to the paper to Geneva Learning Foundation. So that's the short story I have to share concerning HPV vaccination. Thank you very much, Sharon.
Thank you so much, Bilé Nestor, for sharing that story. So we are going towards the end of this particular session on the women who deliver vaccines and HPV vaccination. But I would like to turn to our guide on the side once again after listening to these two different experiences. What are your thoughts? What are your insights? And what maybe key takeaways should participants go back with today after listening to this as far as HPV vaccination is concerned?
Thanks, Charlotte, and thank you so much to the two presenters just now for very, very different contexts, but very interesting stories of HPV information. I think the main key takeaways for me is that we're seeing very different contexts between Cameroon and Nigeria, one where introduction happened, but unfortunately was low coverage, and Nigeria is coming up to its own introduction. I think there's a lot of learning that Nigeria can absolutely gain from some of those other experiences. And I'm noting the importance of engaging not just teachers, but also religious leaders, of course, as well as professional bodies such as medical associations, which in other countries we found can also oppose or on the other side really support the HPV vaccine, and that can lead to better uptake. I think what's very interesting in what Fanny had shared is emphasizing this link between HPV and cervical cancer, which might sound obvious, but I think sometimes some of the information around HPV, because it can be linked to sexual and reproductive health or family planning, then people are a lot more hesitant, whereas if you're able to re-emphasize the cervical cancer prevention narrative, is something that has been very powerful. I'm based in Rwanda, and every time there are cervical cancer prevention activities, the HPV vaccine is always mentioned, and that really helps building confidence. And maybe the main key takeaways that I'm taking away from this conversation, and I hope everybody else is the real impact that each of us can have if we see ourselves as HPV champions and think about how we can implement that vision of being a champion in our own specific context. Maybe I'm gonna end there.
Okay, thank you so much, Laura. And I see there's a comment in the chat from Gabriela by Damba Timbo from Sierra Leone, who says HPV vaccination was the biggest success. As I hear stories from colleagues, I now see the extra intervention we did for our success. So Gabriela, I see your mic is already open. Please, can you tell us a little bit more? What did you do in Sierra Leone to attain 92% coverage of HPV for HPV vaccination? Over to you, and please do start by introducing yourself.
Good morning, and thank you, everybody. I hope everybody is hearing me. I am Jibrila Badimba Timbo, a CHO in Sierra Leone. I'm a medical assistant, but I'm attached to the EPI program national as the M&E officer and the data management, the head of the data. There are a lot of things Sierra Leone did, which I have observed is not mentioned here. Firstly, we involved in the micro planning. We involved everybody from we started involving the paramount. These are the kings of each of the chiefdoms, because there were about 152 chiefdoms in the district, and these are, I mean, the local leaders in those communities in the micro planning process. Again, we involved the Ministry of Education at the highest level. We involved the first lady of the country, right, in the micro planning process. We involved teachers, right, the headmasters of all schools, right, and then in the micro planning we even involved the Statistics Sierra Leone, right. That is the people that are responsible to give us data about the population we are going to target, right. So it was from the onset at the micro planning level. We involved every stakeholder so that we can have a success. And what was very, very clear, that came out very clear, was the involvement of the class masters in hiving out the age that was necessary, and then preparing those students at class level, and then providing this data for us so that prior to the intervention, right? And then after all the micro planning and after all the work we have done, I had the opportunity now to supervise a specific district, and that was Koinadugu district. right? And then there I saw the glaringly clear, I saw glaringly the successes we did in terms of allowing the big community stakeholders to be part of our microplanning, particularly education and the paramount chiefs and other stakeholders, right? I involved myself in Koinadugu, a Muslim-dominated community, right? And that has communities that come from neighboring Guinea that are sometimes resistant to immunization. So the district director of education was part of our intervention during that time. And there were schools after some time who were not so sure for us to do the immunization session. But fortunately for us, the district director had a letter from the Ministry of Education, directly from the Ministry of Education, which we had copies, which we shared to all the schools at that time. And we used him in our radio panel discussions every evening to discuss the issue. There were the little bit of resistance we are getting at that time were easily resolved. And he was very, very active in going down to schools together with us in vehicles and community. And the beautiful thing about Sierra Leone is we did the intervention with COVID-19 vaccine. When we did the HPV intervention, the COVID vaccination also shut up, you know, because there were children in the school who haven't taken the vaccination at that time, right? Who were not taking COVID and who saw HPV as an opportunity, right? They too were vaccinated equally. And one case stood out clearly, one secondary school stood out clearly. It was a mission school that had wanted to, that did not want to take the vaccine, right? Well, what we did was with the social mobilization, as me from the national level, worked with the social mobilization officer. We went to the director of education of the district, and then we engaged him. We went to the school collectively. He, of course, haven't already called him in Freetown in the microplanning process, haven't already taken him, not having adequate knowledge of what to say. We allowed him to address the schools, and then everything went on smoothly, right? There were no refusals again, and then in fact, there were more people coming for the vaccines that we weren't even thinking we would get such coverages, right? Because there were groups that were coming whose age difference, because our target group was just one cohort, right? And there are other people begging now that why have we left them out? And why are we not covering those groups that are above the age groups we have? But we told them, you know, the vaccines were not adequate at that time, and therefore we tailored the vaccine to a specific age group so that the interventions could, we could not miss, I would not want to take a big number of children and then the vaccines got shocked. So we targeted a special group of children, age group, and then gave the vaccination. So the big problem we have in Sierra Leone now is a lot of people want the vaccines now, particularly the age between 11 to 14 years, but the vaccines are not adequate for them. And everybody now wants the HPV vaccine, but it's no longer, we do not have adequate vaccines for the vaccination. Unlike other countries generally, Sierra Leone is so much receptive about vaccination, that's for sure, right? It is true that there are few people who come from the neighboring countries, particularly Guinea-Conakry, right, who generally, because of their religious background and some ethnicities, who usually refuse. But we were able to convince them. They were part of the vaccination session. We used their community leaders in this intervention. And to us, the success was the Ministry of Health and Sanitation. It was for the Ministry of Health and Sanitation was the involvement of the schools the paramount chiefs.
Thank you very much indeed, Jibrila Badaimba Timbo from Sierra Leone. There's a lot there. I invite you to reflect on this as we thank the Women Who Deliver Vaccines Collective for speaking out about HPV. 600,000 new cervical cancer cases each year. 340,000 deaths each year. And think about, in your country, are people scared of cancer? If so, this is a vaccine that can save them, prevent them from catching one or developing one kind of cancer, and one that may be a significant cause of mortality and morbidity in your country. So, and we're now going to switch over to the next segment. We're going to switch gears, but not really. This Manifesto for Global Health is probably going to mention and share the vision that women who deliver vaccines, as well as men who support them, have for HPV vaccination. The Manifesto for Global Health is an open source version 1 document. It's really a draft or a pre-draft, and what we're doing is we've reached out to the community of movement leaders from Immunization Agenda 2030 all over the world. We've reached out to Teach to Reach participants, and we've asked you a set of questions. And we know we sent you almost one question per day ahead of Teach to Reach. And as we saw earlier, let me just go back to those slides, as we're now in the main plenary. 1,051 experiences were shared. And you can see the questions in relation to the manifesto are about the future of health, about the value of peer learning, about the importance of digital technologies, about working in the humanitarian setting, about building trust with the communities you serve. And we received 642 contributions from the English speakers, you can see here, by country. Now, some of the questions we asked you, some colleagues who work at the global level, some of them said, well, how are people who work in a district or a facility going to answer questions about the vision that they have for health in 2030? And we said, oh, really? Why would they not have a vision for what health looks like 7 years from now? And we actually believe that asking you these questions about vision, about strategy, can help break through the bubble of what and the ways in which we are stuck in global health on a number of fronts, by going to those of you who are doing the most critical work on the front lines, where at the end of the day, it is what you do or do not do that will determine if a child receives the vaccines they need, if a family is protected from disease and death, from vaccine preventable diseases. So we asked you questions such as, what will health system transformation look like where you work? We asked you also, how is sharing experience different from having global health experts or hierarchical superiors tell you what to do? We asked you, how has the digital revolution affected your work? And of course, we also asked you how your work has been affected by the COVID-19 pandemic. So we're going to go to that first question I showed you. What will be different when you work for health in 2030? So in our Zoom studio, if you're in Hopin, if you're on YouTube or Facebook or Twitter or LinkedIn, you can answer this question. We'll be looking at your comments. If you're in Hopin, we'll be looking at your comments as well. Let me see what's happening now. All right, so we got Anisha who says hello everyone. Anish, I hope you're going to take the time to answer this question. What do you think health, your work, the work that you do in health will look like by 2030? And then for those of you in our Zoom studio, we're going to call for volunteers who would like to answer this question, or else we may volunteer you because we know you, and we know many of you have, through the work that you do, have insights and reflections to share. Let's go to Penelope Masumbu from Zambia. Penelope Masumbu, I hope you'll be able to speak to us. We have one hand raised from Abdullahi Umar and Melissa Teferi as well. Penelope, are you able to speak to us? All right. And then Let's try David Naboare from Ghana. And then I see that I'm going to go to the hands raised. Charlotte, are you able to tell in what order the hands were raised so we can try to respect that?
Yes, Reda, it was Melese Teferi first, and then we have Boma, and then
all right. All right, so let's
David Naboare. Mic is open, but we can't hear him.
All right, David, are you able to make your microphone work?
I'm here. Can you hear me?
Yes, loud and clear.
Yes.
Okay, thank you very much for this opportunity. And I think for the question, all that I think is we ought to prioritize our public health intervention systems. So by doing that, we need technologies to be roped into our main interventional programs, because this is the time we need to actually move into the 21st century of delivering health intervention policies across. Notwithstanding, we need more public health advocacy to be able to reach out to our population, and more education should be conducted to get the public to understand what we actually need them to do when it comes to this. And more experts should be trained in that regard. We need more experts. So this is what I have for now. Thank you very much. Thank you very much.
And David, thank you for this contribution. How do you think that advocacy and that is going to happen? What can you do where you work in order to support that?
So with the advocacy, what I do is that you have to, first of all, look at the health intervention policy you are going to look at, like prioritizing immunization programs in our district. All that we have to do, who are the stakeholders in this particular enterprise of our interventions? The church leaders.
Oh, did we just lose David? Charlotte, are you able to hear him?
No, Reda, his mic is still open, but I can't hear him.
Nope. All right. Okay, we lost him. Let's go then to, let's see. All right, we have many hands raised on this one. This is not, so wait, I just saw Florence Kabuga, keeping in mind our rules for public speaking, which is if a man has spoken, the next speaker should be a woman. Florence, are you able to speak to us? I saw your hand raised. We'd love to hear from you. What is your vision for what working for health looks like in 2030? What is different? What is the change that is needed? And how do we make that change happen?
Thank you so much, Leda. I'm Florence from Kenya. I look at health in 2020, just like the previous speaker. Technology is picking up, and so we will be doing a lot of consultancy through technology. You can be referred to an X-ray, and the X-ray will be reviewed, and you will be put on treatment, and just walk to a chemist and buy your medication. And looking at the human resource for health, we can see a lot of challenges. In some of our countries, there is a lot of movement from one country to the other in search of green pastures. And so the current shortages moving forward will be addressed by technology. Yes.
All right, thank you, Florence. And can you tell us, Florence, where you work and what you do?
I am a public health nurse. I work in Kenya. I'm currently supporting the national program in trainings, developing digital materials for trainings, and a lot of mentorship.
Thank you very much, Florence. This written contribution from Dr. Faiza Rabbani. Then I'm going to take a look on social media and the conference platform. So Dr. Rabbani says, though it is the third year in progress of Immunization Agenda 2030, an increasing realization for the subject, if the process remains smooth, hopefully we would be way ahead in improving quality of life, as well as there will be marked decrease in burden of disease caused by vaccine-preventable disease. There is increasing need to work on universal health coverage at primary healthcare level. Charlotte, who shall we hear from next? I believe is it Melese Teferi?
Yes, Reda, it's Melese.
Wonderful.
Mic is already open.
All right.
Thank you, Carlo. Thank you. I'm really happy to share my thoughts. So it's really important to have evidence-based interventional healthcare strategies that really address and build plan based on the available data that maybe clearly shows that the gaps in intervention, the gaps in immunization activities. For example, if we don't know where to act, if we don't know what the gap is, it's really too impossible to address the immunization program. So evidence-based interventional activities is very important. So everybody in the healthcare activities need to have, based on the data that's available, to strengthen and to capacitate even the professionals working in healthcare programs. I think it's good to have evidence-based interventional healthcare or immunization program. Mostly, especially in developing countries, including Ethiopia, we already used the traditional way of healthcare planning as well as intervention. So it's really good to have real that we have. Thank you.
Wonderful. Thank you very much indeed. Let's now go to Dr. Tusime Ramadan. We met, Charlotte and I met Dr. Tusime Ramadan last week in Kampala and learned that he works on the border with the Democratic Republic of Congo. And Dr. Tusime Ramadan, we're especially, yes, given the circumstances and the context in which you work, eager to hear what is your vision, what will be different when you work for health in 2030. But please do introduce yourself first and foremost.
Are you hearing me?
Yes, this can you the sound? Yes, please.
Yeah, this is Dr. Ramadan from Uganda, a retired medical doctor working in Western Uganda near the Congo border. The vision will be good because now people are getting used to vaccinations. The disbelief that immunization had other motives is going out of people. And 7 years to go from now, by 2030, I think immunization will be adopted by very many people. And that's my vision. And I think that when we work hard, hand in hand, and we get more knowledge from other experts, we share knowledge. So by 2030, hello?
Yes, thank you, Dr. Tusime. Can you tell us what currently, what do you do in at the border with DRC when there is an epidemic outbreak? What is it that you and your organization do? All right. Unfortunately, we may not find.
We are affiliated under. Hello?
Yes, please go ahead, but we're having trouble hearing you.
Under the Ministry of... Hello, are you getting me?
Yes, please proceed.
Hello. We are affiliated under the Ministry of Health, and there are always outbreaks in DRC, so contracted to immunize and do immunization work under the Ministry of Health. And rampant emergencies split and cover parts of Congo up to our country. So what we do is that we are given work to do an implementing role for the Ministry of Health, and then we're involved in immunization. Time to time, we do that.
Okay. Understood. Thank you, Tusime. All right, Charlotte, I see many raised hands. Let me go just, let's have a quick look on social media and elsewhere to get a sense of what is happening. Okay, here. All right, we have Noazou. All right, let me get a little. Yeah, Noazou Ruahu Victoria, who says there will be more awareness and less ignorance, thereby providing more preventing measures over health issues. So that is one, that is Noazou Ruahu perspective. Anisha says, I have planned to conduct the health activities in the in the ground level to mobilize the health workers for community service in more effective ways and apply the data of health to change till 2030. Aliyu Ibrahim says, I will put everything I have learned into practice, and I will make sure that I create a very good relationship between the health facility and the communities. And Anish Shah adds, my advocacy will be in the ground level to help all activities to implement the changes in the health sector. Let's go have a look on the Hopin website. So there are, all right, so Gift Anyam says we will need to have more program in the health sector integrated together so that we can achieve one purpose, which is to have universal health coverage. Thank you, Gift, for this contribution, but let's go to the stage and see what the contributions are here. All right, the people are still introducing themselves, which is fine, and do tell us, we're interested in what is your vision. What is your vision for the future of health? We had a number of questions. What will health system transformation look like where you work? And we've received hundreds of insights, experiences, analyses in response to these questions. How is sharing experience different from having global health experts or your hierarchical superiors tell you what to do? How has the digital revolution affected your work, and how has your work been affected by the COVID-19 pandemic? So let's go back to the room. I see many hands raised. We appreciate the written contributions. Mohamed Suleiman Yabzai, I wish you were making these contributions on the conference platform itself, but perhaps you're having access problems. Charlotte, who shall we hear from next? Oh, Charlotte?
Sorry, madam, I'm muted. I got initially allowed Boma Otobo to be able to speak in respect of our gender equality measures. I don't know if Boma is still able to, and then I'm also allowing Hassan Benya to be able to speak.
All right, let's hear from Boma first. And Boma, remind us who you are and what you do, please.
Okay, thank you so much. My name is Boma Otobo. I'm retired from the National Primary Healthcare Development Agency as the Deputy Program Manager in MERIC, but currently working with medicines, technologies, and pharmaceutical services. That's MTAPS. It's a USAID-funded program in Lagos, and presently expanding the COVID vaccination coverage to the private facilities. We all know that quite a good number of the community members do visit the private facilities instead of the public. So we are ensuring that they are also being captured with the COVID vaccination. Yeah, so one of the things under the Gavi 5.0 strategy is leaving no one behind with immunization by 2030. And we all know that this has been inspired by the SDGs and also in alignment with the IA 2030 goal. In terms of gender and equity, for equity, we all know that there are a lot of marginalized and vulnerable populations. But we have to find a way to break this, be able to reach them so that all the children are able to access vaccines. Access, you know how it is with the low and middle income countries, not having adequate access. So one of the things we expect by 2030 is that the systems would have been so strengthened so that delivery of PSC services will become easier. And as universal health coverage by 2030. Talking about gender, specifically, I would like to comment the role of women who deliver vaccines. That's my own constituency, one of the founding members of that great work. Without women, like I do tell people in the community, we will not be able to reach the mothers, we will not be able to reach our fathers, who actually are the ones that control the women in quote. So in terms of ensuring that more women are trained, we have to open up the spectrum so that wherever trainings are going on, we try to ensure that we have more allocation to the women, because eventually this will be the ones that we rely on to take our messages, to take our programs to the communities. They are the ones that can easily go into the homes, knock on the mothers and ask them to bring out their children to the facilities. So we don't want to see by 2030 where there's any, how do I put it? We don't want to see fewer women. Instead, we rather have women take their roles and ensure that they are the ones that are driving all these goals. Well, I would also like to say that my colleagues have also talked about human resources for health. You see, in the future, which is the 2030, we will still continue to have shortages of human resources. But one way we're going to overcome this is by doing what we call task shifting, right? We need to train, task shift this other category of healthcare workers so that they will become easily available to us when we need our programs. And lastly, for technology, it's going to save a lot of time, it's going to save money, and it's going to increase the access, because with just the click of a button, you'll be able to send out messages to thousands of people, reminders, and so on. So all of this, we hope to see that it will help what we do at our various fields. And I would like to thank Reda, thank Charlotte, and the rest of the team. This Teach to Reach Connect is something I would not even want to miss, and I hope we still have many more of it in the future. Over. Thank you, Reda.
Thank you so much, Boma.
All right. Thank you, Boma. I was muted, Charlotte, of course. Thank you, Boma, a longtime scholar and movement leader, the Movement for Immunization Agenda 2030. We are opening up the discussion really for the very first time around the Manifesto for Global Health. We've shared with all scholars, Teach to Reach participants, and members of the Movement for Immunization Agenda a version 1.0, and it is open source. So open source is a term used in information technology and software by software developers to describe something that is constantly changing, that everyone can contribute to. And this is why we're inviting you. We shared these questions, and over 1,200 of you have already shared experiences, insights, analyses, and we are working towards version 2.0, which will be a version owned by this community of immunization and primary healthcare practitioners, about answering the question, what do we want to be different when we work for health in 2030, and what are we going to do in order to get there, and who else needs to do something in order to achieve that vision. We can always issue strategies and policies top down, from the global level to the regions to the countries, to you who work in districts, facilities, regions, or we can try something new, something different, which is giving everybody a voice and leaving no one behind. Back to you, Charlotte. We have time maybe for one more person to contribute, share their contribution to this manifesto for global health.
Yes, Reda, and Hassan Benya already has his mic open, so over to you, Hassan, and please do start by introducing yourself.
Yeah, good afternoon from Sierra Leone. I'm Hassan Benya, working for the Clean Health Access Initiative, Sierra Leone, as a senior data analyst. So my experience so far, I think for us to really get a very good system that will change across the board has to do with data. In the sense that one thing I experienced within the health system, we've been able to get a lot of leadership skills, and then we've also been able to get a very good human resource. regardless of the limited number of human resources. But I will tell you that in quality improvements, the number of human resources we have already, definitely those people are, even though they are not enough, but they are up to task to really responsible to change the health system. So in a common sense, the major goal is we need to really focus on data. That is to say, we need to employ more data analytics people who can actually look at the health interventions across the board and then also profile solutions. If I can give you a vivid example of the HPV introduction, which we did in Sierra Leone, we actually use QGIS, which is a data-based app, to really position where there is high number of children within 10 years old, and then also with that we are able to identify facilities that have high number of children within that particular community. So as a result, we are able to achieve our 90% above coverage due to all those interventions, using only data. So that is telling us that if we employ more again of health informatics within the system, by 2030, definitely there will be a lot of changes, because that simply means we'll be doing focused intervention. Using data, we can be able to identify defaulters, and of those defaulters, we can easily target them, we track them, and then give them the required dose. Same thing goes to zero dose. So if we use all this approach, it's a good way for us to improve on our system. Then of course, in terms of the community service, I know we have existing structures in most countries. In my country, we have the CHWs, which is the community health officers, healthcare workers. These guys are actually trained already. These guys are doing very well. But the major point is just to back up with a data for them to do a focused intervention. For instance, if you know that particular community is hard to reach, make sure that you provide the required data. Identify all the children that are not vaccinated. So when the intervention is going on, the vaccinators are going there. They go directly to those ends. So I think those are the areas I think we need to do. Then lastly, for digital challenge, I think that one is cuts across. Is something that I would say is a work in progress. If we focus on that, definitely we'll succeed in the future. For the purpose of time, I stop here. Over to you.
Thank you very much indeed. All right, Charlotte, do you see one more person perhaps to speak to these questions and contribute to the manifesto, or shall we move on to the next segment, which is really what leaders of the Movement for Immunization Agenda 2030 are doing right now, have been doing in the last year to lead change?
I think we can move forward, Reda. And I'm sure maybe with time we'll get more and more people, and you can continue to share your thoughts and your vision in the chat.
All right. Wonderful. Then we'll be following up on the process for contributing to the manifesto. There have already been, so we've been overwhelmed by the number of contributions received. We have our Insights unit working to make sense of everything you've been telling us and working on a revised draft. We'll then invite you to review the draft and further contribute to it. So we hope that we'll share more details about that process. But I want to go back in time to the 7th of March 2022. And many of you in the room in Teach to Reach 8 today in our Zoom studio know that was the date, the 7th of March 2022, when you joined the Movement for Immunization Agenda 2030. Now, this was a 4-month learning cycle in which you worked intensively together to do a number of things, starting by sharing ideas and practices and figuring out what the ideas and practices of others meant to you, moving on to situation analysis, diagnosing the root cause of an immunization challenge that you face where you work, in your facility, in your district, in your region, in your country if you work at the national level. Moving on to then identifying corrective actions. This was in May 2022. Over 1,000 members of the Movement for IA 2030 developed action plans. These action plans were finalized on the 17th of June 2022 at Teach to Reach 6, and we're now more than 1 year later. And we're going to hear in this next segment what have leaders of the movement done in implementing. How has it turned out? Has it actually made a difference? These are the kinds of questions that we want to explore now in this segment. Before we do, we're pleased to share the first 3 IA 2030 movement implementation case studies, and you're going to see 3 faces of leaders that you may or may not know, starting with Wesnam from Senegal. Wesnam, a midwife in Senegal, was shipped off to run a health post in rural Senegal with little experience of immunization and country backup. And she says it was a colleague, a fellow scholar, fellow leader of the movement for IA 2030, who showed her how to keep an immunization registry, who showed her the basics of running her facility. With the support of that scholar and other leaders, she's been able to take the Penta 3 coverage from 8% when she arrived to more than 80%. Think about it. And she says that many of the ideas that she used came from the movement and from Teach to Reach. For example, she introduced vaccine angels as community liaison points, so peer educators, caregivers who function as peer educators. And that idea she first heard at Teach to Reach. Second leader is Frank Monga, District Medical Officer in Lumumbashi. Now, he's been participating in the TGLF network, and he introduced a token scheme to catch up on zero-dose children in the DRC. And he was selected in July 2019 to lead the national network in the country. And this network has grown to the point where the Ministry of Health, the national planners, attend the meetings led by Frank and his peers because it is an incredibly useful way to get information from all over the country. Think about it. These are achievements of leaders of the movement for Immunization Agenda 2030. Our movement is global. And so the third case study is Maria Fernanda Manzan, who runs a primary healthcare center in Corrientes, Argentina. And she's focused on enhancing coverage in a nearby slum area where the population is not motivated to seek immunization services. These 3 case studies are available now. We've shared the links with all Teach to Reach participants. Go, you may be inspired, you may find useful ideas and practices that you can use in your implementation. We're now going to turn to some of the implementers, some of the leaders of IA 2030 who've been working for more than a year now on their implementing their action plans. We've recently asked them to share an acceleration report, what we call Acceleration to Impact, in which we asked them to update us on how their implementation is going. Charlotte, I hear an open microphone, so I'm guessing you already have the first IA 2030 leader ready to speak.
Yes, Reda, we have Kingsley Ninyere that is here. So Kingsley, warm welcome to you, and please do start by introducing yourself.
Thank you very much for the opportunity. I'm Kingsley Ninyere. Hello? Yeah, I'm Kingsley Ninyere, working with Community Youth Development Foundation in Ghana. Yeah, with regards to my situation analysis or my action plan, my challenge was negative attitude towards COVID-19 and malaria vaccine. And in fact, relating to this problem that I had in my district, which is negative attitude towards COVID-19 and malaria vaccine, the community were viewed that this newly introduced vaccine was introduced to render them impotent. And being someone who wants to bring behavioral change communication, I embarked on what we call community sensitization. I collaborate with the municipal management team and then the vaccination team. while we are doing the sensitization, the first two are also doing the vaccination along the side. And it will interest you to know that a community that was identified in the Nkranza North district saying they are COVID-19 vaccine hesitants. Per our sensitization, in fact, we were able to vaccinate more than 50 people within a day. And I think that was a plus that very day. Coupled with the malaria vaccine, which was also a challenge, the Ministry of Health has developed an intervention and they've introduced malaria vaccine, which is the RTSS, solely for children under 5. That is to say 6 months, 7 months, 8 months, 9 months, and then 2 years. And being being someone who wants to bring about who wants to bring about behavioral change communication, that intervention has served as a catalyst to me. And then I have to make sure that I do more and more of the sensitization at the house to house, one-on-one, and then community information centers. And by so doing, people now are freely going to the vaccinating centers to vaccinate their children. And I think for now, I've also interviewed about 7 districts, sub-districts within the municipality, of which the disease control officers that are in charge confirmed to me that, in fact, with regards to the RTSS, that is a malaria vaccine, it has its uppers. That is to say, the number has increased more than they used to have for the previous years. And I think it's also a plus. So with regards to my action plan, in fact, it has yielded the fruitful results in the Kintampo municipality with regards to the malaria vaccine and that of the COVID-19 vaccine.
Kingsley, sorry to interrupt, but I'm not sure I understand. Can I ask you a few questions? Because I don't understand. So it was your IA 2030 action plan focused on COVID-19 vaccine or on malaria vaccine?
It was both. That is COVID-19 vaccine and the malaria.
Okay, yeah. And so what has changed through the work that you have done? What is different now compared to a year ago? Is there better acceptance?
The challenge was Hello, come on.
Yes, go ahead.
Yes, my challenge was negative attitude towards COVID-19 and malaria vaccine. And that is what I embarked on the sensitization with regards to these 2 vaccines.
Okay, very interesting. So from the outset, you decided to take an integrated approach, combining just linking COVID-19 and malaria. And so what is different in terms of attitudes and behaviors of the community? How do you know? And what is different in terms of vaccine coverage?
With regards to malaria, before the action plan was developed, I have a chance to meet with the 7 sub-district of the disease control officers to inquire from them how is the malaria vaccine coverage with regards to their various sub-districts. And in fact, the performance by then was very low. So per my sensitization and also the intervention that the Ministry of Health has brought on board by seeing that children under 5 who goes for immunization or CWC, that's a child welfare clinic, should be immunized against malaria. And that one, when I went back again to interview the disease control officers for the various 7 districts, they confirmed to me and they will show me the records. And I can see that there is much improvement as compared to 2021. And then with regards to the COVID-19 too, by then the coverage was 40% in the Kintampo municipality. So my organization, which is a Community Youth Development Foundation, who is carrying out community sensitization, has to collaborate with the Ghana Health Services as well as the COVID-19 vaccinators. So we do house-to-house sensitization alongside with the vaccinators. So whosoever we are able to convince by our sensitization, then the vaccinators will also vaccinate the person that very time without any hesitancy. So I think there has been much improvement with regards to the two vaccines that was my challenge in the Kintampo municipality.
Thank you, Kingsley Niniere from Ghana. Thank you for helping me understand. Now, the question is: so you joined the Movement for Immunization Agenda on the 7th of March, 2022. You participated in many of the intense learning activities. How did that actually help you with this, with your action plan? What did you gain by participating in the activities, sharing your experiences with your colleagues, listening and learning to the experiences of others, sharing your own experiences, doing root cause analysis, doing mapping out corrective actions? What difference did that make for you, if any?
With regards to
Oh, I think we lost you, Kingsley. Yeah, please go ahead.
by then, to even select, I hope you can hear me now.
Yes, you're back. Yep.
Yes, to even select my title or my challenge was not easy to come by, but the idea engine has helped me to identify my main challenge within the district. And then with regards to the idea engine, it has also made me to get my key area of focus. And that key area of focus was what I actually used to carry out my sensitization. And then how to even identify some of the stakeholders within the community to carry out the sensitization activity, it wasn't easy. So this, as I joined the movement, it has helped me to identify some of the key stakeholders within the community so that I collaborate with them to do the mobilization. And then when I get there, I'm able to do the sensitization. Notwithstanding that, it has also helped me to identify some of the community health volunteers within the various selected communities that are intended in my project. So those volunteers also assisted me in doing the mobilization. Mothers, they have helped me. And during the peer review of others, during the situation analysis,
All right, I think you're coming in and out. We've lost you, Kingsley, but thank you for sharing. I think we understand.
During the review, it has given out my plan, and which has helped me. Thank you very much.
Thank you very much indeed. We're talking about what movement leaders are doing with their Immunization Agenda 2030 action plans, what they're actually implementing and what difference it's making, how being part of this global peer learning network through Teach to Reach, through various activities of the Movement for Immunization Agenda 2030 can actually help you do better, work faster and better in a connected way, getting inputs, ideas, practices from all over the world in order to figure out which ones you need will actually be helpful to you where you are with respect to your immunization challenge. So that is what we're doing now. Let's go have a look on social media and let's see. All right. Oh, okay. There's a lot there. We're not going to be able to do everything. Charlotte, is there one more IA 2030 implementer that we're going to hear from? Charlotte, you're muted.
Sorry, Reda. I see Castro Pojebong. His hand is raised. I know he's a long-time member of the movement for IA 2030. I'm inviting Castro to unmute.
All right.
Castro, are you able to, let me see if I allow him to speak?
All right, we've only got 12 minutes left, and then we have a special focus on Nigeria, and we'll tell you more about it and the Zero Dose Learning Hub in the final minutes of this segment to show you where to go. It's not going to happen here in the plenary or in the stage. It's going to happen in the sessions. So I'm going to show you that in a few minutes. Special focus on Nigeria. Welcome to you, Castro Fogembong. Please introduce yourself. Tell us who you are, where you work, when you joined the movement for IA 2030, and then we'll ask you about your action plan.
Good afternoon. This is Castro from Ghana. working in the Lambusier District Health Administration in the Upper West Region, Disease Control Officer.
All right.
Can
So,
you hear me?
yes, loud and clear, Castro. So, when did you join the movement for IA 2030?
I joined the movement IA 2030 in March 2022.
And what was the challenge, the immunization challenge that you decided to take on?
My immunization challenge was access and then utilization. We have low access coverage in terms of antigen, always below 90%. And most of my sub-district, not all, at the end of the year usually have low utilization, more traveling out. So my action plan was to take some corrective measures and work towards to achieve the coverage. Comparatively,
So
we have
wait,
taken
before
so
you tell
far
us,
some corrective measures.
before you tell us about your
Hello?
action plan, yes, what was the root cause of your challenge? What was the root cause of the problem that you then tried to solve with your action plan?
We identify some of them to be large immunization sessions. Some were having larger numbers in sessions, which usually cause inconvenience. So I intend to reduce the waiting time. And we realized that some of the community health workers find it difficult to keep track of their defaulted tracing. So we intend to develop an e-tracker, electronic tracker, whereby even if the mother delivered at the facility, the child name will be entered and it will be monitoring when the child is due to remind the caregivers and then to try to plan immunization sessions with caregivers to always decide who day is convenient for them.
All right. And so now tell us about the corrective actions that you've taken over the past year. What have you done and what difference has it made? How has it turned out?
So far, we have actually been able to reduce the larger numbers of immunization sessions. Some were having as high as 100 attendance per session. So we are able to reduce them to 30, a minimum of 30 per session, and that has increased our immunization outreach sessions and then static services. We've been able to develop the e-tracker. That was even 2021, but some facilities were not able to utilize this, but were able to put it into practice. And it has helped a lot in identifying and then keeping track of defaulters. So if the child is due, then some days the child will be due, it will highlight green, and then the CHO will start keep tracking of those children. So before the CHO even gets to the outreach session or they prepare for the static, the community health officer already know the number of children he or she expects and they know the number of vaccines to carry along. We've been able to organize some form of WhatsApp group among caregivers. So those who are electronically inclined, they join these platforms and then their weighing sessions, immunization sessions are being communicated through the WhatsApp platforms for them to keep reminding their colleagues of when to attend weighing sessions. So far, we've been able to have an engagement with stakeholders, organize some good number of community debates to sensitize mothers about the importance of immunization, and now to extend immunization coverages, immunization sessions to some schools, the KGs, under 5, so that children who are due and probably the mother was not able to pick them to the outreach session or the static, the CHOs, the community health officers goes there to immunize these children during the school sessions.
Understood. Thank you for sharing this implementation story, Castro Fogambong. My next question for you is, so you participated in the full learning cycle between March and June 2022. You engaged in many different peer learning activities, shared experience with your colleagues, they shared experience with you. What difference did it make? How was it actually helpful to you? That's what we'd like to know.
It has actually been helpful to me. I've learned from a colleague, and that is, if you really want people to accept the package, immunization package you have, then you have to plan the sessions with them. So I've realized and I've introduced this in most of the communities. Some of them, usually they decide when they will be available to organize the immunization sessions. But when I've introduced this one, caregivers got to understand, and then some of them really appreciate that. Sometimes they wish that immunization sessions should not be organized during their market days or when they have funerals, because they will not have time to attend to them. So it actually helps me to keep track and have confidence that bit by bit we will achieve our target, and every child, and then on the immunized children will be reached.
Thank you very much indeed, Castro Fogembong from Ghana. One more implementation story, and remember there were more than 1,000 action plans developed in May 2022 in a period of just 2 weeks, and we've asked leaders of the movement to share what we call an acceleration report, so we can get the updates and understand what are you doing with these action plans. Some of you may have stopped, some of you may have been successful in implementing them. In that case, we want to hear the story of that as well. And as I said, we've published several stories, including those from Westam Faye from Senegal, Frank Monga from the DRC, Maria Fernanda Manzan, but we will not stop until we have 1,000 action plans. And for those of you who are new to the movement, who have not joined yet this movement for Immunization Agenda 2030, the world's strategy adopted unanimously at the World Health Assembly in 2020. You're going to receive the invitation as a Teach to Reach participant to join this movement and also develop your own IA 2030 action plan. Begin thinking through that process from learning to action to results, ultimately to impact. Want to congratulate and thank the IA 2030 implementers who've spoken today. Many did not get to speak as there were 1,000 action plans. We hope that you found these stories, these experiences useful. By participating in activities of the movement, you can continuously learn and change and gain experiences and share your own, building a kind of virtuous circle of learning and change. So now, this has been the main plenary. It is now time to close the plenary. You may be surprised, but remember, this is about networking. And so we asked you, which networking session are you most interested in and why? So the options are: networking session 1 is what is the future of health? And there you get to press a button, you connect to a colleague and get to speak with them in a one-to-one conversation. What will be different when you work for health in 2030? Networking 2, what's your toughest immunization challenge? So think about it. What's your most difficult challenge? What's its cause? And then you can ask why 5 times about this challenge to find the root cause. If you work in the humanitarian settings, we have some suggested questions for you. And if you've used oral cholera vaccine, and as you look at, if you've heard voices today of who is in the room, think about what would you want to know about their experience and what you can learn from them, as well as what they can learn from you and your experience. And networking 3, this is a question that got the most responses and experiences shared, is really, why do you work for health? So there is one more thing though, and that is an incredible opportunity specifically for Nigerian scholars, even though scholars from other countries are welcome. I'm going to show you what is happening and why you should be interested, especially if you are from Nigeria. So let's go. You'll need to go to Hopin. So if you haven't registered yet, you haven't been able to access this platform that I'm showing you now, you're going to have to do that in order to access the following session. You'll go to sessions. You've been to the stage to watch the plenary and the tutorial and the warm-up. You've been to the networking. That's where you connect with others. And now we have the Nigeria introducing the Gavi Zero Dose Learning Hub. So in this session, AFINET, organization, a Pan-African organization based in Nigeria, will introduce the Gavi Zero Dose Learning Hub and the Nigeria Country Learning Hub to Teach to Reach participants. So what you do is you click there, and all right. All right, and I'm going to rudely interrupt. I see there are already people in this session, and Yahya Mohammed, our partner from the Country Learning Hub from Afinet, from the Gavi Zero Dose Learning Hub, is already set up with his slides. So now the next step is for me to share with you the link so that you can access this session. So you have to make a decision. Do you want to go straight to networking, or do you want to go learn about this Country Learning Hub for Immunization Equity, the Zero Dose Learning Hub in Nigeria? This is a Gavi-supported project. The Geneva Learning Foundation is Gavi's global partner. I'm going to leave the room so I don't disrupt. Okay, I'm not disrupting. So the Geneva Learning Foundation is Gavi's global learning partner, and working with 4 countries right now: Bangladesh, Mali, Uganda, and Nigeria. So this is the first Country Learning Hub to present at Teach to Reach. And so let me give you now the link. I'm going to give the link first to those of you who are in our Zoom studio. And it is actually time to join. So so now either you go, join the presentation of the Nigeria Country Learning Hub for Zero Dose. And here is the link. So you should see a link in the chat. Whoops, actually I posted it, not in Zoom. Yeah. All right, let me do this here. And then I'm also going to post an announcement in the, let me see, here. So let me do a new announcement. So starting now, the presentation of the Zero Dose Learning Hub. Here we go. So everyone who is in Hopin should receive that announcement together with the link. Now you do have the choice of going to the let me share back. Of going to networking, and we've shown you how that works, but we recommend the session with Nigerian Country Learning Hub, the first time that the Gavi Zero Dose Learning Hub is making a presentation in the context of a Teach to Reach. Wish to thank Yahya Mohammed from Afinet, who is Gavi's Country Learning Hub partner for Zero Dose, and wish you a good, productive session. Now, we're going to close this plenary. So please, I'm going to share again the link to join the presentation of the Nigeria Zero Dose Country Learning Hub. Let me just go back to the reception. You can see what else is happening in Teach to Reach by going to the schedule here. So you can interact with people in one-to-one meetings, or you can go to the introduction of the Gavi Zero Dose Learning Hub. That is entirely up to you which one of these you do. That's it for today. Remember, the plenary is only the beginning, is actually just a warm-up for what we do at Teach to Reach. The core, the heart of Teach to Reach is the networking. So we hope you'll overcome the hurdles of getting into Hopin, and that you'll be able to join. When you click on the link, you get to a registration screen. Don't be scared, you can register, it's free, and you can go from there. All right. Thank you. Incredible testimonials. Of course, not every guest of honor was able to share their story. When we have such a large movement, such a large event, that is inevitable, and I hope you won't hold it against us. Once again, 1,251 experiences shared ahead of Teach to Reach, 642 of them in English. We asked you questions about oral cholera vaccine. 26 of you shared specific experiences. How do you see the future of health? 61 contributions. How has sharing experience with colleagues helped you in your daily work? And this was just the beginning. You can see the contributions by country. And I'd like to end by running again this series of all the contributors that will be receiving a letter of merit, thanking them for their contribution, from Afghanistan, from Angola, Argentina, Bangladesh, Botswana, Cameroon, Burundi, Canada, Eritrea, Ethiopia, Gambia, Ghana, Guatemala, Guinea, Indonesia, Iraq, Kenya, Lesotho, Liberia, Malawi, Maldives, Nigeria, Niger, Pakistan, Papua New Guinea, Philippines, Saudi Arabia, Sierra Leone, Somalia, South Africa, South Sudan, Sri Lanka, South Sudan, Sri Lanka, Tanzania, Uganda. We're not done yet. So many contributions from the USA, Zambia, Zimbabwe, and then international contributors. Teach to Reach belongs to you. All of the knowledge you share will be given back to you. We'll be sharing the full set of insights, of stories, of experiences with you as a Teach to Reach participant, and it'll be going into the Knowledge to Action Hub to become an open source resource for everyone that you can access right now. Now, in case you haven't seen it, you can look at the summary of the insights shared at Teach to Reach 7, where 14,134 of you shared insights and experiences. And again, today, I want to congratulate you for making Teach to Reach such a continuing success. 16,835 people registered, are participating. Many of them had connectivity issues today. That is the norm that we live with. But it's about building connections between each other. There's not so much a relationship you have with the Geneva Learning Foundation as it is between peers, between colleagues. We heard women who deliver vaccines, the stark reality of HPV, 600,000 new cervical cancer cases each year, 340,000 deaths each year. And then we opened the discussion on the Manifesto for Global Health. It is an open source document, and we're inviting every one of you to contribute, whoever you are, whatever you do. If you work in immunization, in health, and global health, we'd like you to help. We invite you to build this document so it becomes a collective, community-owned manifesto for global health. And then finally, in the plenary, we heard implementation stories of IA 2030, implementation plans by movement leaders such as Westam Faye, who took coverage for Penta 3 from 8 to over 80%, set up peer learning programs. And when we asked her how she did it, she said she did it thanks to Teach to Reach, thanks to fellow participants from all over the world who shared ideas and practices. That is the power of peer learning. Leaders like Frank Manga, who set up a token scheme to catch zero-dose children. And then Maria Fernanda Manzan in Argentina, who runs a primary healthcare center, who's also become the first subnational immunization leader to join the working groups for Immunization 2030. We'll invite you to join the movement very soon, for those of you who are just discovering that this is happening. But really, we want to thank you once again for joining Teach to Reach. Again, I'll share the links. If you haven't joined yet, the session for Nigeria, and then if you want to go network, this is the link for you. Thank you for listening, for being here. Many of you, in some cases, you've been here for all 8 Teach to Reaches plus the conference. But whether that's your case or whether this was your first time, we hope you found it useful. I wish to congratulate you for for the thirst to learn, to continuously learn, to do better in your work. Thank you very much. Wishing you a wonderful afternoon, evening, or good night, depending on where you are. Take care.